I'm Dr. Salil Khandwala, and I'm the medical director at Advanced Urogynecology of Michigan. Our practice is a subspecialty practice that manages the female pelvic floor conditions, and a lot of information about our practice is available on www.augm.org. Today, let me discuss with you what is the management of bladder pain syndrome, a very common condition in women, but unfortunately, highly and very frequently misdiagnosed and mismanaged. So, bladder pain syndrome or painful bladder syndrome is a chronic pelvic pain or pressure or discomfort condition that is perceived to be related to the bladder with one other urinary symptom such as increased daytime or nighttime frequency, but most importantly, in the absence of a bladder infection or any other bladder pathology. So let us review the anatomy of the urinary system. So we've got two kidneys, one in on each side, and this is in the upper back. So you've got one kidney on each side. The kidneys essentially filter the blood and produce the urine, and the urine is then transported by these two tubes, one on each side, called the ureters, into the bladder. Now, the ureters open up into the bladder at these two openings called the ureteric orifices, and that pours the urine into the bladder, and the bladder mainly acts as a storage organ. This is the urethra, which is the tube that brings the urine to the outside. It is usually closed as the bladder is storing it. It only opens up like now when you are actually urinating. And all this is controlled by the nervous system. So this is the side view profile of a woman standing up. So head is here, feet are here, front is here, the back is here, just to give you an orientation. This is the pubic bone, the bladder is up here, the urethra is the tube that brings the urine on the outside, behind that is the vagina, the uterus is on the top, and then the rectum, and then the buttocks. So this is how the female pelvic organs are positioned, as can be seen in profile. The problem with bladder pain syndrome is typically considered to be a nerve imbalance, and that's an imbalance between the A fiber and the C fiber. The A fibers classically carry a sensation of pressure and touch. In the bladder, it is a sensation of fullness. So as your bladder is filling up right now, as I'm talking to you, you can ignore your bladder because the A fibers can be essentially ignored and they can tolerate well. However, the C fibers, on the other hand, carry the sensation of pain and temperature. In the bladder, that amounts to urgency, increasing urgency, bordering onto discomfort. So for example, if your C fibers were to be active and as I'm talking and you're trying to listen, you would have to pause me and then go to the bathroom and empty your bladder or else you will not be able to focus as it will cause increasing discomfort and urgency. Normally in the bladder, the A fibers are active, so that's good. And you just feel the sensation of fullness and you say, okay, that's all right, I can go later on. But if the C fibers become active, then you have to attend to them right away because it's going to cause worsening urgency, worsening pressure, and you have to relieve that discomfort. So this is what happens in bladder pain syndrome. The C fibers take over and there's a shift in balance, and the C fibers are now the dominant nerves instead of the A fibers. So when that happens, you get the classic symptoms, and we'll talk about that in a few seconds. The second theory is something called the gag layer disruption theory. And for example, this is the bladder right here. This is the urethral tube. So you can see that this inside is the bladder lining, and the lining has got this layer called the gag layer, GAG layer, or the glucose aminoglycans layer. And this layer acts like a nice little coat and protects the nerves up here from the urine in the bladder cavity. So this is the gag layer right here, as you can see. And then you have the cells of the bladder lining called the urothelium. So all this acts as what's called a urine tissue barrier. So this barrier prevents the urine, which is beyond this, from coming in contact with the nerves down here, because if these nerves get irritated by the urine solutes, then it can cause activation of the C fibers. So let's see what happens. Remember that gag layer I talked about, which is right here? Now there's a break. You see, it's missing here. Now the urine solutes can come through the cells and irritate those nerves and can cause the C fiber activation, inflammatory response, and urgency sensation. So what does the patient typically complain of who has this problem of bladder pain syndrome? Now this affects the entire female pelvic viscera. In the front where the bladder is, it's urgency, frequency, discomfort if she has to hold too long, and a sensation of incomplete bladder emptying. So guess what do these symptoms remind you of? Urgency, frequency, discomfort, and feeling that you gotta keep going to the bathroom? A urinary tract infection, that's right. However, in this case, remember what I mentioned, there is no urinary tract infection, there is no bacteria in the bladder, the urine culture is completely normal. Symptoms are identical without an infection. These patients also are usually very young, very healthy, or they could have a very proper pelvic floor without any disruption of pelvic floor anatomy, and they typically will not leak. They may just lose a couple of drops, but it's not that they have the urgency and the urine comes out as what happens in patients with urgency incontinence. In the middle, in the vagina, they may have discomfort either at the vaginal opening or with deep penetration, and they may have symptoms of irritable bowel syndrome or IBS with constipation and diarrhea alternating. And in the entire pelvic area, they may have pelvic pressure, pelvic discomfort, pelvic pain, and also sensation as though something is falling out of the vagina or a sensation of prolapse without there being any true prolapse. So on examination, so as you can look, this is a patient in a lithotomy position. This is the vaginal opening right here. This is the mons pubis with the pubic hair. And this is the clitoris. This is the thick lip of the labia. This is the thin lip of the labia. And then this is the vaginal cavity inside with the urethra being here. So that's the typical anatomy of the vaginal opening. And just touching gently and lightly with the Q-tip at the vaginal opening can cause significant pain because of the activation of the C fibers, and that is called vulvodynia. Just palpation, a simple palpation of the bladder with the finger in the vagina, just tilting it a little bit, and the patient is saying, ouch, it hurts, and that is bladder tenderness. Despite there being no evidence of any urinary tract infection, the bladder is still tender. Because of the tenderness and the discomfort, the patient automatically has pelvic muscle spasm because the patient is bracing for pain, especially whether naturally or during intercourse. When a partner is about to go in, she knows it's going to hurt as the penis touches the vaginal opening or goes inside and touches the bladder, and she's bracing for discomfort. So these muscles right here, they go into a spasm, and guess what? Then the spasm itself then causes throbbing, discomfort, and pain. So how do we make the diagnosis? The most important thing is the bladder pain syndrome is a diagnosis of symptoms. The urine culture and the urine analysis are essentially negative, so we rule out stuff. We look at urine cytology, especially if there's a blood or a patient is a smoker or there is a family history of bladder cancer. This is like a pap smear or a cytology of the urine, and we look at it and make sure that's fine. But more importantly, this is to rule out things. The common thing is that all this is fine and it is essentially the symptoms. So when we do a 24-hour diary, so essentially we're taking a log of the 24-hour and a 3-day diary, and what does it show? So 24-hour diary is essentially collection of the urine over a 24-hour period. You're not collecting it, you are urinating in a hat, you measure it, and then you throw it away. So as you're doing this, we look at what the volumes are. And typically what you see in bladder pain syndrome is there is decreased bladder compliance. That means small volumes, small urinations, and frequent voids. Patients going a lot more frequently with small amount coming out at each time. So what are the typical normal bladder volumes in a woman? The first sensation, meaning, if someone says, do you feel that there's something in the bladder? And you say, hang on, let me think. And that happens about 100 to 150 ml. So about 3 to 5 ounces. A fullness, which is a good desire to go to the bathroom to urinate. It's not a desperate desire, but a good desire. It means if I had to go, I could go. Happens around 300 to 350 ml. maximum bladder capacity. Maximum, that means, oh my God, I've got to still go. I mean, I can wait for a few minutes, but I really have to run to the bathroom. That is around 500 to 550 ml. So 150, 350, 550 is the numbers you can say. In bladder pain syndrome, these are far lower than that. I mean, sometimes they don't even exceed the first sensation volumes. So this is a classic example of a patient who did a 24-hour diary, and you can see her numbers. She's going very frequently. So we look at the frequency. So she's going almost every hour and sometimes even closer than every hour. And look at her voids. And they're barely anything. She's hardly putting up 100, 100, 150, 75, 60. So that essentially tells you these are numbers essentially for most women, they're below threshold. And this is increased frequency with decreased bladder compliance. When you look at a 3-day diary example, this is what you see. They're all littered with E's. E is when you empty your bladder. So she's going so many times to the bathroom, and 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So she's going 13 times in a day and 3 times at night on an average. So you can clearly see that the patient's frequency is significantly stepped up. Now think about this, 13 times in the day and 3 times at night. So you're almost living in the bathroom. This is what is frequently seen in patients with bladder pain syndrome. Once we have the diaries, then we may do a urodynamic testing, especially for women. Like if you saw in the past screen here, you saw that U1. U1 means when you leak a few drops with a strong urge. She mentioned U1 here, U1 here. So it's a few drops. So you want to know what's going on with the bladder. So, or how well is she emptying, especially if the patient feels that she's not emptying well. Then this is a graphic representation of the bladder as it's being filled up, and that helps us understand a few things. One is the volumes will be low, and that the first sensation will be very soon. As soon as we start filling, she says that, oh, yep, I've got to go. And fullness also happens very, very early, but the bladder capacity may be quite a bit. So in other words, she may notice that her first sensation happens at about 75 ml, and her fullness is typically a good desire to go to the bathroom happens around 100 ml. So 75 and 100, they're very close. But then when the bladder is filled up, she may be able to hold them to up to 400 ml. Now she will have some discomfort as it's getting filled up, but there will be no urine leakage. It's just increasing discomfort as the bladder is getting filled up. Especially in certain cases, who have blood in the urine or history of smoking or bladder cancer, family history, we will look in the bladder, make sure the bladder is okay. So this is a cystoscopy. As you can see that cystoscopy, I'm looking in here. She is lying down and her head is here and she's watching. This is done completely under local anesthesia. And we look inside the bladder and make sure the bladder looks all right. And there is no disease in the bladder. Remember, I initially mentioned bladder pain syndrome is without urinary tract infection, without any bladder pathology. So it's typically done, as I mentioned, in these type of patients, and it shows a normal bladder. Sometimes we may see something called Hunner's ulcers, which I'll show in a few seconds. So this is a normal looking bladder. Now this is where you see red riddled bladder with the red dots. Now this is in the absence of an infection. This area or hyperemia is often considered as part of bladder pain syndrome. And sometimes you may see these stellate, the scarring inside the bladder, like here, and that's called a Hunner's ulcers. So now that we've talked about the history, what the patient complains of, we talked about the examination, we've talked about the workup, we've talked about ruling out a bladder infection and other bladder pathologies. Let us now talk about how do we manage this. So we'll follow what's called the American Urology Association or AUA guidelines as we discuss the management. So they go over it, and remember this used to be in the past called interstitial cystitis or IC as it's listed here. So we did the basic workup, we did all this. Now we come to the first line. They've broken it up into first line, second line, third line, fourth line, and onwards. We have created our own management protocol, and it breaks it up also in a different format that we shall follow. So first and foremost is diet. Key things are understanding that food items can clearly cause a problem and irritate the bladder lining. Remember I told you if the gag layer is broken and if the urine has some products that can irritate the nerve, well, the nerves are going to get irritated. So we have a list of food items that we have provided to you in your handbook, and many of those are BPS friendly. That means you can have those, and some of them are to be avoided. Classically, it's caffeinated beverages, or any spicy food, and a tomato-based food would be something that could potentially aggravate the C fibers. If that happens, there's some basic remedies that you can take, such as pyridium, which is available over the counter. Most of these are quercetin, Preleaf, Urabel. Even a heating pad to the lower abdomen could help with some of these symptoms. The part of the first line also, as we've realized, is stress is very closely linked to bladder pain syndrome. Now, we do not know whether stress causes it or bladder pain syndrome causes stress. But I mean, think about this. If you're going to the bathroom, what I showed you in that voiding diary, 13 times in the day and 3 to 4 times at night, and you're not getting a good night's sleep, anyone would be stressed. And then constantly going. Suppose if you have to attend a meeting and halfway through the meeting, you have to excuse yourself and go to the bathroom. Everybody in the office or at the workplace realizes that you're going to the bathroom so many times. It becomes a point of anxiety and stress. So when the stress increases, that becomes a problem. So our goal is to decrease the stress and to the point where your mind is calm by doing some yogic exercises. In fact, since now I'm a certified yoga instructor and using yoga in pelvic floor medicine, we have come up with a yoga module to help our patients with bladder pain syndrome, and we're about to start our first study. As regards the medications, the classic medication is called a tricyclic antidepressant medication. Now, as I said, antidepressant, but that is not what we're giving this for. It's just a terminology, and the terminology is basically just been around, but basically what it does is a drug like amitriptyline, for example. This is what's called a synapse. Synapse is a nerve ending, and then here is the end receptor. So at the nerve ending, you have the neurotransmitters, in this case serotonin, being released, and as serotonin is getting released, it binds to the receptor and produces an effect. Then it is taken back up. What the SSRIs do, as amitriptyline and the TCA does, is it blocks it. It blocks these receptors so that these agents cannot be picked back up, and that's why it's called a reuptake inhibitor, and that's how it works. So when you look at the dose, its typically starting dose is 25 milligrams, and because it works in that fashion, it is very effective from the point of view of decreasing the pain sensation, at the same time what's called CNS or central nervous system sensitization. So by doing that, you do not feel the discomfort, do not feel the pain, and the dose varies. It starts at 25 milligrams, and based upon how you can tolerate it and how your symptoms are improving, every few days we increase it. So let's say every 4 to 5 days, we go from 25 milligrams, then up to 50 milligrams, and then by about 3 to 4 weeks, we see how symptoms are, and if we need to go up further to 75 milligrams. But mainly titrating the effect and the improvement in your symptoms against the side effects. The success rate is quite high, about 65 to 90% of women notice improvement with the tricyclic antidepressants. So these are the drugs that are typically given in this category. And as you can see that as you go up from amitriptyline to imipramine, the main drugs that we use are amitriptyline, nortriptyline, and desipramine. So these are the three medications which do have some of these other side effects, but main side effect is sedation or drowsiness. So when the patient wakes up in the morning, she feels very groggy, as if there is a fog in front of her. And that usually lifts after a few days. But if it continues, then we may have to modify to a lesser to a medication with lesser side effects. Another medication we could give is hydroxyzine or Vistaril, which is an antihistaminic medication, and it's similar dosage. It's not as successful as amitriptyline or the TCAs, but still has some effect on that. A third very well established medication is Elmiron. And the way it works is, remember I mentioned about the gag layer which coats the inner lining of the bladder, and then it's broken up, it recreates it. See, by recreating the gag layer, it protects the lining and the nerves from the urinary solutes. So that's one. So it's like as though it forms the coat again, and the gag layer is recreated. The other way it works is that the mast cells, it prevents the degranulation. So when they break down, these cells release the inflammatory agent. So once they open up, it prevents them from reforming and reproducing those inflammatory agents. The only problem with Elmeron is that it has to be given twice a day, the 100 milligrams twice a day. People cannot take it three times a day, so we then increase it to 200 milligrams twice a day. The only thing is it takes some time, to coat the entire bladder wall, and it may take up to 3 months before you can see some results. So up to 3 months. The side effect is, some people get concerned about the hair loss, but please remember it's a reversible hair loss. It means once you stop the Elmeron, the hair comes back. And the other main thing that people see is a heartburn. So we monitor the liver functions, especially if the patient has been on it for years. And just because of the cost, it's relatively expensive, and how much time it takes to come to effect, about 3 months, we don't start it immediately, but we put it on the back burner. And even though if that's an FDA-approved medication for this condition. So we talked about the first line, we talked about the second line management. Let's talk about the other medication on the second line called Neurontin or pregabalin or Lyrica. So here you again have that. Remember I talked about that synapse. You have the nerve endings, and what the gabapentin or the pregabalin, these medications do is they bind to this alpha to delta subunit. So by attaching it, what it does, it releases that agent, inhibits certain agents, and through this, it decreases this pain sensation, which is felt by the brain. So that's how this medication works. The gabapentin is mainly for pelvic pain and pressure. So typically, more than the urgency and frequency is given for pelvic pain, vaginal pain, pelvic discomfort. It's a 3 times a day dosing, and we usually start at 100 milligrams at night and then gradually increase it up to 3 times a day. And then eventually, very slowly over the next few weeks, we could go up to almost 300 milligrams 3 times a day. So the main side effect with Neurontin is drowsiness again. Lyrica or pregabalin is the other medication like Neurontin. As I told you, works very similarly. We start at about 50 milligrams twice a day and then can gradually go up until 150 to 300 milligrams daily maximum dose has been achieved. The other treatment that we may do sometimes is a procedure called hydrodistension. Now, this could be either a second or a third line therapy. What that involves is looking inside the bladder under anesthesia this time, and then filling the bladder up by allowing the water to flow freely into the bladder until the bladder can hold no more. So what happens in this case is it's mainly done for women who have decreased bladder compliance. In other words, women who have, remember those low volumes I showed you, the 75 to 50 ml, if they have such low volumes, then what we do is under anesthesia, we let the water flow in by gravity. We're not pushing the water in, we're not, pumping it in, it's just allowing it to flow. Because what happens is under anesthesia now, there is a separation between what the muscle of the bladder can achieve and what the nerves were allowing. Now that the patient is anesthetized, the nerves have been anesthetized and put to sleep. Now the bladder muscle says, okay, let me see how much I can hold. So we allow it. So we let the water flow by gravity, and the muscle just distends and distends and distends, and it can now take over, and it could blow past that sensory threshold of the pain nerves. So by passively filling them, when I say passive, we are not force feeding the bladder. We're just allowing to fill. You'd be surprised that sometimes in a woman that we just saw the diary with 75 to 100 ml, we may be able to put in almost 700 cc's. Then we let it sit for a few minutes, about 3 minutes, let the bladder stay stretched, then we empty it and we refill it and do it 2 times. So this is the goal is that when you stretch that bladder, it's almost like a chapped lip. When a chapped lip, the gag layer, it starts cracking and it again starts rehealing. That's number one. So it recreates or regenerates the gag layer. That's number one. And number two, it resets the C fibers. So for example, if a computer is playing up, what do? You reset it. You turn it off, you turn it back on, just like with your phone, and it starts working again. So this is almost like resetting it by quietening down the C fibers. A delta nerves take over and the symptoms are dramatically better. So that's basically working on the gag layer, as I mentioned. Now, suppose if we see these Hunner's ulcerations when we're doing this, then I would inject a steroid just under the Hunner's ulcers, and that also has an anti-inflammatory property and helps with the bladder pain sensations. It's a very straightforward procedure. It takes about half an hour to perform. Patients are home within an hour. There's a very rarely would they have difficulty emptying. This is very, very rare. And I have never had a bladder injury. It's almost unheard of, especially when it's done at low pressures that we do today. The success rate is very high. So about 60% of women would have almost complete resolution of their symptoms. And they would say, yep, my urgency and my frequency is much better. I do not have to go to the bathroom that much, and it's wonderful. The next day after the procedure, the patient can do everything. There's no restriction after just the day of the procedure. There's restriction because of the anesthetic. But this procedure does not involve any cutting. It's the same thing that we do in the office. The only reason we cannot do this in the office is because of the pain, and therefore the patient has to be put under general anesthesia. The other thing that can be done in the office on a weekly basis is something called bladder instillation therapy. And we use an agent called DMSO, which is a powerful anti-inflammatory agent, with some other agents like heparin, a steroid, and a local anesthetic. And this is put in the bladder once or twice a week. It takes about 20 minutes to do it. Then or not even, about 5 or 10 minutes to do it. And the patient is asked to hold her bladder for 20 minutes, and then she urinates it out. If the DMSO is used, because of its strong smell, it gives a garlic smell on the skin. And it is effective. 93% of the patients had noticed improvement objectively in the number of times that they went to the bathroom, and over half of them noticed significant subjective improvement. The other treatment that can be considered is something called pelvic floor therapy. Now, this is done in ladies with urgency and frequency symptoms, where we help control that by electrical stimulation of the pelvic floor, and in patients with pelvic floor spasm. It's done in the office. It's once a week for 4 to 6 weeks. The procedure lasts about 30 to 45 minutes. There is no discomfort, no pain. There's no prep required before. After she goes home, she can do whatever she wants. There's no limitation. So the beauty of this is it can be done in the office as a simple procedure, and it's a good addition to the other treatments that I've just described. And this is how it's done. The last is something called neuromodulation. And neuromodulation is done for patients with tried everything else. They still have the urgency and the frequency, and we've tried the medications, we've tried the hydrodistension, we've tried everything else. Then it would be useful. So remember, it's only for urgency and frequency, not for pain. And that could be the inner stem, which is a small battery that sits in the butt, and that helps control the bladder nerves and also the urethral nerves. Or we could use Botox, which is done in the office by placing about 0.5 cc of Botox at each point in the bladder wall. It takes about literally 5 minutes to perform in the office. It's done completely under local anesthesia. Though it is mainly indicated for ladies with urgency leakage, it could also be done in patients with urgency and frequency who have not been helped by medications. Or the third is a leg stipulation called PTNS, which is a small little acupuncture-like needle that sits there above the ankle bone. She's reading a magazine for half an hour, and that essentially recalibrates the same nerve that influences the bladder. So all in all, there are several options available, right from dietary modifications to de-stressing to the medications we talked about, the hydrodistension, the pelvic floor therapy, the Elmeron, and then the other things we discussed about in the form of refractory symptoms. Most important thing that you should take home message is that many times this has been labeled as bladder infection. So please be very careful. Even if you are on the treatment and you notice your symptoms have improved, and then you start getting symptoms of urgency and frequency, let's say at about 6 months, do not assume that this is a bladder infection. That's the biggest mistake you can make. Make sure that you get it checked out, because it could very well be a relapse of your bladder symptoms. Most patients have urgency, frequency, and pain. Remember, pain and urgency, frequency, no leakage As I mentioned on exam, they had tenderness at the bladder and at the vaginal opening. The diaries show low bladder capacity. The culture is negative. The cytology is negative. Cystoscopy is normal. The urodynamics only shows discomfort, no true incontinence. And then treatment is based upon our findings, like what I discussed with you. Next step is obviously that once the patient is in remission, she may get what's called flare-ups. If she starts drinking coffee or has a glass of wine, it may bother the bladder, and that is what we need to absolutely control immediately. So please review this video, what I've done, and education material that we've provided, including the dietary aspects. And what I call it's a handshake. It's a handshake between you and me. We have to make sure that we work together, otherwise this is not going to be successful. Remember, the foundation is dietary modifications, exercising, just regular exercising, including yoga and relaxation exercises and mindfulness. We have to be ready for flare-ups, and if they happen, we've got to nip it in the bud. Do not wait too long. Ultimately, we have to have realistic expectations, meaning we may not be completely get this cured, but if we can improve this, that's great. Finally, any treatment has to be balanced, effect versus side effects, and we'll see which is the best treatment option in your case.